topic. This is a very comprehensive topic these days. It is very relevant for the current practice in breast cancer. It may not be relevant to some of them due to our current economic situation. However, it is worth knowing and refreshing the current international guidelines. Maybe one day we'll be able to do better than what the Western world is doing at these days. So we start the immunotherapy in triple-negative breast cancer, current indications and challenges. Triple-negative breast cancer has long represented one of the most challenging and aggressive subtypes we treat, marked by early relapse, limited targets, and historically poor outcomes. Over the past 5 years, however, we have witnessed a true paradigm shift. Immunotherapy has moved from experimental promise to a validated pillar of care in triple-negative breast cancer. I can quote two important trials, Keynote 522 and Keynote 355 in the metastatic setting. Both of them have shown that immune checkpoint blockade can improve both event-free survival and overall survival. Now, we move to the first clinical case. This is my own case. I treated this patient. He was initially diagnosed to have early stage triple-negative breast cancer, aged 48 years old. She was found to have node-positive stage 3B disease. The PD-L1 combined score was 12. So I gave her, as per Keynote study, I gave her a combination of chemotherapy and immunotherapy. This is the outcome post-treatment. Initially, she was found to have a 5-centimeter tumor which had just shrunk. We can see on the right side, which had just shrunk to a small line of the residual disease. She underwent surgery and she was found to have complete pathological response, which is the ultimate outcome we wanted for all our patients being treated with the new adjuvant chemotherapy and then having the surgery. Triple-negative breast cancer, as some of the doctors, new doctors here sitting here would be wondering as to what is triple-negative breast cancer. I need to tell them that triple-negative breast cancer lacks estrogen receptor, progesterone receptor, and HER2 protein. It represents around 10 to 20% of all the patients who are diagnosed and treated with breast cancer. It is very aggressive, very high recurrence rate, and limited target options. This is more common in younger women and those with BRCA1, most BRCA1 mutations. Chemotherapy remains the mainstay of this treatment until the current Keynote studies. Emerging therapies, immunotherapies, targeted treatment, PARP inhibitors are being treated and being given to some of the patients, not worldwide, but to some of the patients at least. Prognosis has historically poor, and both survival and improving with newer strategies. Doctors must be wondering as to why immunotherapy is so important in the triple-negative breast cancer and not other breast cancer like ER positive, which is the most common breast cancer, estrogen receptor positive disease, or sometimes in HER2 positive disease. Triple-negative breast cancer behaves like an immunogenic tumor. It harbors abundant tumor-infiltrating lymphocytes, elevated PD-L1 expression, and neoantigens generated through genomic instability, all of which make it a prime candidate for immune checkpoint blockade. The understanding of immunology active microenvironment has transformed triple-negative breast cancer, which was once purely chemotherapeutic disease, to one where we can give a better outcome, a better outlook for the patients suffering, especially the young patient suffering from the breast cancer. What has changed in the last 5 years? In just 5 years, the landscape of triple-negative breast cancer has transformed dramatically. What was once an experimental idea harnessing the immune system against breast cancer, is now an established guideline, approved standard of care. The Keynote 522 and Keynote 355 trials were true game changers, proving that immunotherapy not only prolongs life survival, but fundamentally improves the outlook of the life, improves the overall survival as well. This is the Keynote 522 trial schema. This is a landmark in the early stage triple negative breast cancer. It redefined our curative intent approach. This was a phase 3 randomized double-blind trial enrolling stage 2 to stage 3 triple negative patients. All these patients received chemotherapy in 2 different blocks. And then one of the 2 groups received immunotherapy and the other one received placebo. The chemotherapy was given in 2 different blocks. In the first block, carboplatin, 3 weekly cycles for 4 cycles, along with paclitaxel weekly for 12 weeks, along with the pembrolizumab given once every 3 weeks. On the other hand, the second block, we gave anthracycline-based standard chemotherapy, well-tested EC chemotherapy, epiribicin and cyclophosphamide. We gave 3 weekly treatment along with the pembrolizumab. The keynote results, as we can see in the Kaplan-Meier graph over there, the yellow line represents patients receiving pembrolizumab plus chemotherapy, while the blue line below shows the chemotherapy alone. We can see a clear and early separation between the 2 curves that remain durable over time. This translates to an 81% event-free survival rate versus 72% with chemotherapy alone. A 33% reduction in the risk of progression or death, which is quite good, quite a big difference. In the post-neoadjuvant setting, although it is not directly related to the immunotherapy, but let me complete this whole protocol of the keynote study. In the post-neoadjuvant setting, the principle is simple but crucial. Continue pembrolizumab after surgery, regardless of the response. For patients with residual disease, we now layer additional evidence-based options called capecitabine through the CREATE-X study and olaparib, a PARP inhibitor from the Olympia study. In those who with germline BRCA mutations, the PARP inhibitors is given to them. This makes early genetic testing very, very essential. Right in the very beginning, at the time of the surgery, at the time of the diagnosis, genetic testing needs to be done. A brief talk about the CREATE-X study. This is the capecitabine. These CREATE-X trial evaluated patients with residual invasive disease after neoadjuvant chemotherapy. If you look at the Kaplan-Meier trial graph, you will notice that the blue line for capecitabine separating early and staying higher throughout the control arm, showing a clear and sustained improvement in disease-free survival. This is the definite benefit. We can see the overall survival remains elevated as well with the capecitabine. These two has evolutionized the whole mechanism of treating triple-negative breast cancer these days. As I mentioned, early genetic testing is very, very essential for the young girls who are still in their 30s or 40s and who needs to live longer, who deserve to live longer. We need to treat them. We need to treat them with the best available treatment. The Olympia trial firmly established the role of adjuvant olaparib as the standard of care for germline BRCA1 or BRCA2, HER2 negative patients. If you look at the Kaplan-Meier graph on that side, it separates from the placebo early and stays higher over the time, demonstrating durable improvement in both invasive disease-free survival and the overall survival. Now, I mentioned that the keynote study showed that we should continue giving the immunotherapy irrespective of the outcome, whether there is any response no response, or residual disease. However, we have been working on this escalation and de-escalation trial. As we refine immunotherapy in triple-negative breast cancer, the next frontier is personalization. Trial like the optimized PCR are asking whether patients who achieve a complete response really need a full year of pembrolizumab, another 7 cycles, or if we can safely shorten them. In my department, 3 of the doctors do not give pembrolizumab to the patients who have achieved complete pathological response. I still give immunotherapy as per keynote study. But there are so many oncologists and there is so much chatting going on whether we should continue giving the pembrolizumab to those who have responded very well. This is a study called Impassion 031 study. I am just including it so that we can explain that we have done the whole immunotherapy. In this one, we see that the Kaplan-Meier curve, the blue line representing the atezolizumab. Instead of the pembrolizumab, we gave the atezolizumab and nab-paclitaxel. The blue line representing the atezolizumab on the right side demonstrates the consistent separation of the for overall survival. Although the hazard ratio favor atezolizumab, the confidence interval include unity, meaning these findings are not statistically significant. Thus, we do not give atezolizumab at the moment. We are only giving pembrolizumab these days. Take home message. Keynote 522. Trial has truly transformed early triple-negative breast cancer management, delivering not only impressive pathological complete response gains, but also durable survival benefits with 1/3 reduction in the risk of death and clear event-free survival improvement. Importantly, these results held up across PD-L1 subgroups, irrespective whether the PD-L1 was low, intermediate, or high. By contrast, unfortunately, the Impassion 031 trial, although accorded the important overall survival benefit, but it did not sustain the complete pathological response. Now we move to the next patient. She's again my patient. She is a metastatic patient, 56 years old, who was found to have metastatic disease with lung and liver. Later, she was diagnosed to have the brain lesions as well. This case highlights the role of immunotherapy in advanced triple-negative breast cancer. This patient presented with metastatic disease involving the lungs and the liver and a high PDL score of around 70, I think it was 70. She received pembrolizumab-based chemotherapy and achieved a partial response with stable disease maintained over time. She is still alive. We can see the liver lesions on the left side, and the liver lesions after some time had disappeared, and she has remained stable all along. I am now talking about the Keynote 355 study. This evaluated pembrolizumab plus chemotherapy as a first-line therapy for metastatic or inoperable triple-negative breast cancer. If you look at the study, and on the top right, patients were randomized 2:1 to pembrolizumab with chemotherapy versus placebo. Treatment continued until progression or unacceptable toxicity. Now focusing on the Kaplan-Meier curve below, the green line represents the benefit of the immunotherapy as compared to the chemotherapy alone. Again, I would like just to briefly discuss about the role of Impassion 130 study evaluating atezolizumab plus nab-paclitaxel versus chemotherapy alone in metastatic triple-negative breast cancer. Looking at the Kaplan-Meier curves on the top left, you see a modest progression-free survival. But the key finding comes from the PD-L1 positive subgroup. The top right, here the PFS, progression-free survival, improved significantly with atezolizumab, but it was not maintained in the disease-free survival benefit. So take-home message comparing Impassion 130 and Impassion 131. Impassion 131 is a negative study, so I did not want to waste your time discussing Impassion 13 study. And the Keynote 355 study. When we look across these pivotal trials, we see that the full story of immunotherapy in triple-negative breast cancer unfolding. Impassion 13 proved that atezolizumab with nab-paclitaxel could meaningfully extend survival in PD-L1 positive patients. Impassion 131 reminded that the chemotherapy partners matters. What type of the chemotherapy is being used in the Impassion 131 trial? With the paclitaxel, the benefit was lost like due to the steroid interference. On the other hand, we see that the Keynote 355 confirmed and expanded the benefit of pembrolizumab plus chemotherapy, showing consistent overall survival benefit in the PD-L1 positive patients, tumor across multiple chemotherapy schedules, cementing chemotherapy plus pembrolizumab as the current standard of care in the first line of triple-negative breast cancer. Now, testing the PD-L1 even in the Western world is a headache. It requires whether we are using the pembrolizumab and we are using the 22C3 CPS or using the atezolizumab, which is now luckily not being used, and we do not need to. The two assays don't agree. The concordance is very limited. It is around 60%, but in real world it is less than 60%. But luckily, we have been using now only one assay, and this is for the pembrolizumab. Sequencing, the next thing. Today, the treatment sequencing in triple-negative breast cancer is largely guided by the PD-L1 status. For patients with CPS of more than 10, we prioritize immunotherapy, typically pembrolizumab, followed by an antibody drug conjugate. It is not licensed in UK. It is licensed in the Eastern European countries as well as in America. Immunotherapy is not approved by the NICE, as I mentioned. In this subgroup, looking ahead, emerging trials are testing immunotherapy with antibody drug conjugates are being used. Briefly, in 30 seconds, I would like just to mention the managing the immune-related toxicity. I believe one of the other doctor has already discussed briefly about it. Immune checkpoint inhibitors unleash the immune system, and with that power comes risk. Unlike chemotherapy, toxicities are not dose-dependent and can occur at any time and mimic autoimmune disease. The key principle, the word, it's itis. It could be colitis, it could be hepatitis, it could be nephritis, it could be hypophysitis, it could be thyroiditis, anything. It is always think of immune-related toxicity if the person has been on the immunotherapy in the recent past and comes to you with any of the new, be it a trivial symptom. It could be related to the immunotherapy. Immunotherapy must be individualized, although most of the trials have not included these patients, but it all depends on the clinician's judgment. In my practice and all my colleagues in my department, they try to give patients, even if they do suffer from autoimmune disease, as long as the patient is good and stable with the autoimmune disease treatment. Some patients who have been on transplant, they are receiving autoimmune treatment as well. I have never tried any patient who being on the pregnancy, who is pregnant and I'm giving her, but I am told that they have been tried. Now, the biomarkers beyond PD-L1, as our understanding of the triple-negative breast cancer biology deepens, several biomarkers have emerged, but none of them have yet displaced PD-L1 in clinical decision-making. I can tell you about the tumor-infiltrating lymphocytes. It's a very valuable prognostic information, but do not predict immunotherapy response. Tumor mutational burden, very high, or MSI in the colorectal cancer, exceedingly rare in the breast cancer. Though when patients present with this thing, immunotherapy really works very, very effectively. We have seen good 3 or 4 patients in my department where they were found to have this MSI high and they were treated and they got a good response to this treatment. The gray zones, despite major advances, several gray zones persist in the immunotherapy for triple-negative breast cancer. We still grapple with the SCA discordance between 22C3 and the SP142. I know the atezolizumab is being given in some parts of the world, is still being given. Uncertainty about the ideal chemotherapy backbone and the unanswered question of how long to continue immunotherapy. Re-challenging after toxicity, managing CNS disease, and addressing non-responders all demand individual decisions. Future directions. The next wave of innovation is in triple-negative breast cancer is already reshaping our landscape. Combination strategies, as I mentioned, immunotherapy plus antibody drug conjugate is being tried and tested and is being approved in FDA or in some other Western European countries. Immunotherapy has undeniably transformed the triple-negative breast cancer landscape, offering durable benefit where few options once existed. Pembrolizumab now defines the standard of care in both new adjuvant setting as well as in the metastatic setting. Thank you very much.
Thank you, Dr. Khalid Hameed.